everyone, welcome once again to What's Made Easy. My name is Dr. Beston Mwila, and today we're going to be diving into yet another interesting topic, which is the management of diabetes ketoacidosis in internal medicine. Okay, so if you haven't yet subscribed to my YouTube channel, please hit the subscribe button. Please like and share with your friends so that you are able to view this content each time I post. Okay, so with that being said, let's begin. We're already behind time, and time is clicking, my friends. So let's start. So how do we manage diabetes ketoacidosis in internal medicine? We've talked about diabetes acidosis, diabetic acidosis, and if this is the first video that you're watching, please go back and watch the video so that you know where we're coming from. We've already talked about diabetic ketoacidosis and how it occurs and how you diagnose it. And now we're dealing with the management. We've already covered on how you manage it in pediatrics, and today we're going to be talking about how you manage DKA in internal medicine in adults. Okay, so first of all, remember that each management is obviously going to begin with your diagnosis. So how are you going to make your diagnosis? Your diagnosis of DKA is going to be dependent on the number one. So we're dealing with DKA. Okay, DKA management in INED, okay, in internal medicine. Okay, DKA management of DKA in internal medicine. Okay, so how are we going to make this diagnosis so that we arrive at a diagnosis and we know what we're managing? Okay, so we start off with our history. Obviously, this is the patient. This is someone who's going to present with those key features we talked about. They may come in with polyuria. They may give you a history of polyuria. Okay, they may give you a history of polydipsia, which is excessive thirst. Okay, excessive urinating, excessive thirst. They may give you a history of weight loss. So weight loss. Okay, so all these histories, maybe confusion. Okay, all these things may be there when you do your history taking. You do your physical examination. I think we talked about all these things. On your physical examination, this is a patient who may have these non-labored but deep, rapid and deep respiration, which we call Kussmaul respiration, Kussmaul breathing. Okay, they may have this Kussmaul breathing. They may have this acetone breath. So acetone breath. Okay, they may have the acetone breath. They may have Kussmaul's respiration. They may have the acetone breath. They may have an altered mental status. May have altered mental status. May have altered mental status. It's a patient who may be vomiting. As you examine, you may find this patient is vomiting. The patient may have signs of dehydration. Okay, dehydration. They may be dehydrated. So once you have a patient that presents like this, okay, and you make a suspicion, you suspect to say this patient may be having DKA, the next thing that you do is that you are obviously going to do some of the tests, okay, investigations that you do to try and diagnose. So you will find that you do your RBS, the tests that you do. After that is you're going to do your RBS, and for you to say this is DKA in internal medicine, the RBS is supposed to be greater than, okay, RBS is supposed to be greater than or equal to 13.9 millimoles per liter. So RBS is supposed to be greater than or equal to 13.9 millimoles per liter. Your ketones, then you check your ketones, isn't it? So on the ketones, you are supposed to, you know what we do here in our setup especially is you are going to check your ketones through urine. So you do your dipstick. So when you do your dipstick ketonuria, you find that you have 2+ ketones, okay, greater than or equal to 2+ ketones on dipstick. So that this now gives you a confirmation to say, okay, what I'm dealing with in the presence of these symptoms, in the presence of this type of physical examination, these findings on my physical examination, and RBS is 13.9 and ketones is greater than or equal to 2+ on dipstick, this is probably me dealing with DKA, okay? And after that, you are going to order for your investigations. So what investigations are you going to order for? What investigations do you order for? So what other investigations are you going to order for in this particular patient? What other investigations do you order for? So this is where you are going to do your full blood count, obviously do your FBC, DC. Remember that one of the most common the most common cause or trigger of DKA is infection. So obviously your FBC and differential count is going to give you the white cell count, and you'll be able to see if at all you have an elevated white cell count, which could signify that you have an infection that you're dealing with. You do your U and Is, urea electrolytes, and creatinine, okay? Urea electrolytes and creatinine, very important. You want to assess your renal functions. How is the liver functioning? Your electrolytes. Remember, you can end up with an electrolyte imbalance in a patient with DKA. This is a patient who's vomiting already. So that already the vomiting and the fluid loss, the dehydration, it gives you electrolyte imbalances. So you need to do your U and Is and creatinine to assess the renal functions as well. Okay. It's a patient you want to do your arterial blood gases, your ABGs, okay? Remember the pH, you can get the pH from here of blood, okay? It can give you the partial pressures of carbon dioxide, partial pressures of oxygen, it can give you bicarbonate levels. So all these, you can determine them on ABGs because this patient is already in acidosis, and the type of acidosis, remember, is they are going to be in metabolic acidosis. High anion gap metabolic acidosis, where the anion gap is above 12. And I think this is something that we talked about. If you didn't listen, if you didn't watch the video that we did previously, please go back and watch the video where you have the introduction and other things on DKA. This is just the management. Okay, you do your ABGs, you do your ECG, you can do your ECG / your echo. Okay, remember that you can have electrolyte imbalances that can give you arrhythmias. That's why you need to do your ECG, and they'll give you cardiac problems, obviously. Apart from that, it's also important to do your ECG because as you manage this patient, as you resuscitate, remember we talked about the potassium, very, very important. As you resuscitate, this patient may slide into hypokalemia, okay, may slide into hypokalemia, and you can detect that when you do your ECG, okay. This is for hypokalemia, okay. I think these are some of the important investigations that you can order for, okay. Now, having ordered the investigations that you needed, what's the next step? How do you treat the DKA now? Okay, having understood all these concepts, how then are we going to treat DKA? How then would we manage DKA? So in internal, the management of DKA, remember our mnemonic, our very good mnemonic that we used last time we were talking about pediatrics. The mnemonic is FIPA, isn't it? FIPA, FIPA. Okay, that's the mnemonic you use in the management of DKA. Isn't that beautiful? I don't think you can even forget this. So you start off with resuscitation. Okay, first of all, you have to resuscitate. Then you do your FIPA. F-I, okay, P-A-A. You've managed the DKA, isn't it? So resuscitation, start with our resuscitation. So first things first, remember that DKA is an emergency. DKA is a medical emergency. It's a life-threatening complication of diabetes mellitus. Remember our definition, life-threatening complication of diabetes mellitus, which is usually seen in patients with type 1 diabetes, but it's not uncommon to see it even in type 2 diabetes nowadays, okay? So your first thing, because it's a medical emergency, is to do resuscitation. So your resuscitation is going to be, you call for help, call for help. So first thing is call for help. You can't manage an emergency alone. So make sure you call for help. Do your ABCDs. Okay? Do your ABCDs. Your A is your airway. Make sure the airway is patent. Make sure the airway is patent. make sure the airway is patent. If there are any secretions, make sure you suction the secretions. If this is a patient who has low GCS, if the GCS is low, to protect the airway, if they can't maintain their own airway respiration, you need to insert an NGT, okay, because they cannot protect the airway. That will prevent aspiration, okay. Make sure the air is patent. If there are any secretions, make sure you suction, okay. You move on to your B, okay. We're here, air B, breathing, okay. This is breathing. So this is where you are supposed to check, ensure that the chest is moving with respiration, chest movements, and this is where you even be able to detect your Kussmaul's respiration as well. Okay, you appreciate them there. Count your respiratory rate, check your SpO2, and if at all you find that your SpO2, your saturations are low, this is the point at which you can start the patient, put the patient on O2, put the patient on oxygen if indicated, if the saturations are low. Okay, put the patients on the oxygen. Then C is for circulation. So circulation now, this is where you are supposed to check your vitals. Okay, what vitals are we talking about? Check your BP. Remember, this patient has polyuria, and because they are urinating a lot and they are vomiting, they are losing out fluids, and because those fluids, that fluid is being lost, you are going to find that this patient goes into dehydration and can go into hypovolemia and shock. So check your blood pressure, check your pulse rate, check your capillary refill time, check the peripheries if they are warm or cold, plus the temperature as well, plus the temperature as well. This patient may have had an infection, you can have a fever, okay, on this patient. Under circulation, IV access. So obtain IV access, very, very important. So you are going to cannulate, obtain 2 large bore cannula, insert 2 large bore cannula. So if you are able to cannulate, you can insert one here and another one here. So 2 large bore cannula, okay, 2 large bore cannula, at least a green one, okay, at least 18G, 16G, 2 large bore cannula. You need to insert 2 large bore cannula. That's your IV access. And when you cannulate this patient, you obtain IV access, draw samples for your labs. Okay, this is where now you even get blood for your labs, for your investigations, for your full blood count, for all other investigations, electrolytes, ABGs. That is where you draw your samples to send to the lab. Okay, apart from this, this is where now you are also supposed to start on IV fluids, but we will talk about IV fluids later. Let me skip it a little bit. So you need to start on IV fluids here, but you are resuscitating. So D is for disability. Okay, so please, under circulation, the other thing you need to do is you want to monitor the urine output. So because you want to monitor the urine output, don't forget to catheterize this patient. Don't forget to catheterize this patient, because you need to catheterize this patient. Why? Because this patient can go into dehydration, can go into hypovolemia and shock, and that means that they can have impaired blood supply to the kidneys, and that can send them into pre-renal acute renal failure because of reduced supply of blood to the kidneys. So you need to catheterize to monitor the urine output. The urine output, which should at least be above which should be greater than or equal to 0.5 mils per kg per hour. Okay, that is the normal urine output. So you find that if the urine output is low, resuscitate with IV fluids to raise the urine output. Disability, this is where you check your GCS. GCS is the Glasgow Coma Scale, and this one will tell you the level of consciousness. The level of consciousness. So if the patient is not fully conscious, they are gasping or something, you need to insert an NGT. So you need to insert an NGT. Insert an NGT so that their airway is protected so that they do not aspirate. Now, after you've done this resuscitation of the patient, this is where now you are going to start on, you move on to the F. So what is F about? What is the F all about? So the F in FIPA, you start now with FIPA. After resuscitation, this is when you move to FIPA. F. F is for fluids. Okay, so these are the principles of management. The F is hydrate the patient with the IV fluids. Okay, now these fluids, what fluids are you giving? So as you assess, you did your rapid assessment during your resuscitation, and your BPs and everything helped you to check if this patient was dehydrated. You proceed here. If the patient was in shock, you manage as a shock protocol, and then you continue managing as DKA here. So now, how do you give your fluids in DKA? The fluid of choice in DKA is 0.9% normal saline. So 0.9% normal saline is the fluid of choice. So how do you give this 0.9% normal saline? So how you are going to give this is, you are going to start off with 1 liter. You give 1 liter in the first 30 minutes. So in 30 minutes, 1 liter in 30 minutes, you give another liter over 1 hour. Then you give another 1 liter of normal saline over 2 hours. Then you are going to give another 1 liter of normal saline over 4 hours. So after you give this, you give 1 liter in 30 minutes, you give another liter in 1 hour, you give another liter over 2 hours, and another liter over 4 hours. After you're done doing this, then you assess, make sure you assess the hydration status. After you give like that, make sure you now assess the hydration status of the patient. Okay, after you give the fluids like this. Okay, now this is how you are going to be given. Now, as you give these fluids, you are supposed to be checking your RBS. Make sure you're checking your RBS after. So you check your RBS. RBS should be checked every after 30 minutes. So half hourly. So you are going to be doing RBS half hourly, RBS half hourly every after 30 minutes as you resuscitate like this. Now, as you do that, when the RBS of the patient falls within the ranges, if the RBS falls below, so you're checking your RBS. So if your RBS falls below 13.9, between this and 8, so it's below 13.9, between 8 millimoles per liter and 13.9, below 13.9. If the RBS falls within these ranges, you are going to switch from the 0.9% normal saline that you are giving, you are going to switch and start giving 5% dextrose. So you start the patient on 5% dextrose. If the RBS, when the RBS falls below 8, between 8 and 4 millimoles per liter, when the RBS falls between 4 and 8 millimoles per liter, okay, you are supposed to switch the fluid, start the patient on 10% dextrose. That's the IV fluid you are going to start giving this patient. When the RBS falls below 4 millimoles per liter, what you do is, this patient is already in hypoglycemia. The reason why you are switching when the RBS falls below 13.9 is because you want to prevent hypoglycemia. The reason you are switching between this, you want to prevent hypoglycemia. And when the patient is in hypoglycemia, it falls below 4, RBS falls below 4, you are going to give 40 to 50. Okay, you are going to give 40 to 50 mils of 50%, okay, 40 to 50 mils of 50% dextrose. So you start the patient, you switch the fluid, you give the patient 40 to 50 mils of 50% dextrose to resuscitate them so that the RBS goes up, okay, to clear out that. So this is how you are going to be doing your fluid management in DKA in adults. So fluids, we've ticked, resuscitated fluids. We move to the next principle of management, which is correct, okay, which is correct the hyperglycemia with insulin. Correct the hyperglycemia with insulin. Okay? With insulin. So now, how do we correct the hyperglycemia with insulin? How do we administer this insulin then so that we're able to correct the hyperglycemia that this patient has? So insulin is going to be given. So remember, one point I should mention is that you are going to give, remember that when you give insulin, insulin is going to start shifting the potassium back into the cells. I think, remember our explanation, we said because of this acidosis that comes because of the presence of ketones in blood. Ketones in blood tend to donate a proton. When they donate a proton, remember, they are going to lower the pH, meaning you go into acidosis. So because of the acidic nature of the blood, you have a lot of hydrogen in the blood because of this donating of a proton. So to try and buffer up, what your cells do is that they are going to shift, they are going to get now your hydrogen, take it into the cells in exchange for potassium. So potassium comes into your blood circulation, your hydrogen goes inside the cells, and because your kidneys are functioning properly, remember there was already potassium there. So you put more potassium, it's like you are increasing potassium, so it will filter out the excess. So you urinate out the excess. Okay, so what you have is you have normal levels of potassium within your blood. They could be normal, a bit elevated, but normal levels of potassium in the blood. But the thing is that it's not normal levels of potassium in the body because a lot of it are shifted from the cells, it's in the blood, and you filtered a lot of it out. So within the blood, it's normal. But what if it goes back where it belongs? Now, when you start your insulin, the potassium is going to go back where it belongs. So you end up with hypokalemia. You understand? You end up with hypokalemia because as you start your insulin is going to activate the sodium potassium pump to start pumping the potassium back into circulation, into the cells. Okay, so you may go into hypokalemia. So what you do is, even before you start the insulin itself, you start first of all, let at least the fluid first of all, start resuscitating with the fluid a little bit, okay, at least a liter, and then commence the patient on insulin. Okay, at least let a liter run and then commence the patient on insulin. Okay, because you can't start administering potassium there and then. So the reason is because you start your fluids, okay, let it run at least a liter, then you start your insulin. When your urine output is okay, then you can also start your potassium. So how do you give the insulin now? Because you want to correct the hyperglycemia. Insulin is given at 0.1 international units per kg per hour. So this is the dose of insulin you are going to be given in DKA. So this is the dose you are going to be given. You are going to be giving it IV as an infusion. Okay, 0.1 international units per kg per hour IV. Okay, insulin. Okay. Now, how do you give this 0.1 international units? So what you do is you get that vial of insulin. Okay, you get that vial of insulin. So you are going to get 50 international units. So that thing contains 50. So you draw the 50 international units, you put it in 500 mils of normal saline. So when you get 50 international units, you put it in 500 mils of normal saline. What you are going to have is as good as saying you have 1 international unit in every 10 mils. Okay, because it's like this goes in this is 1, this goes in this, it's 10. So you have, it's like when you draw 10 mils from that 500 mils of normal saline, that thing you have, it will give you 1 international unit in 10 mils. Okay, in 10 mils. So this is what you have. So now, I'll give an example. If this is a 25 kg individual, let's say 45 kg man. Okay, if this man is 45 kg, let's say the weight of this patient is 45 kg. So if this patient is 45 kg, how are you going to do this? So what you do is, because it's 0.1 international per kg per hour, you say 45, so it will be 45 kgs. It's going to be 45 kgs multiplied by 0.1 international units per kg per hour. So this kg will cancel with this. When you multiply this, it will give you 4.5 international units per hour. So this is the dose of insulin that this individual needs to get. It's 4.5 international units per hour. So how are you going to do this? So what you do here is that, remember you already have this. What you want to give is not international units per hour, because this insulin is already dissolved in normal saline. So you need to know how many meals am I going to give per hour so that I come up with 4.5 international units per hour. So how do? You convert this international units to meals. So you already have this. So you have 1 international unit is equals to 10 meals. That's what you say. Then what about 4.5 international units is going to be x. So you multiply. So your x is going to be 45 meals per hour. So meaning this individual is supposed to receive 45 meals per hour of this fluid that has got insulin in it to deliver 4.5 international units per hour. So you get this 45 meals per hour. When you get that fluid that you've already added 50, you put it on an infusion pump. Then you set the rate at 45 meals per hour, and that is what the patient is going to be receiving. Okay, this is how we are going to be giving the insulin. So as you give the insulin, make sure already you are still monitoring. Remember, you are checking your RBS. So check your RBS regularly. Every 30 minutes, you're checking your RBS. When your RBS, okay, when your RBS falls below 13.9, when RBS falls below 13.9, 14.9 millimoles per liter, what do? You have half the dose of insulin. Why? You want to prevent hypoglycemia. So half the dose of insulin, meaning since you are giving 0.1 international units, you are now going to be giving 0.05 international units per kg per hour. When the RBS falls below 4, you are going to switch to 40 to 50 mils of 50%. You give 40 to 50 mils of 50% dextrose, and you're going to be you give this every 25 minutes. So you're going to be giving every 25 minutes 40 to 50, every 25 minutes 40 to 50, until the RBS of this patient rises above 6 millimoles per liter. Okay, that means you put them out of the hypoglycemia. So that is how we are going to be giving your insulin in DKA. So let's move now to P, which is potassium. So I've already explained as to why this is potassium. So so this is your other principle of management. Replace electrolyte, correct electrolyte imbalances, specifically potassium management. So I've already explained as to why the potassium will fall, because it will shift back into the cells and then it will fall. So there are circumstances in which you give the potassium. So you give the potassium when your urine output is okay. So if at all, so don't give potassium if you have peaked T-waves on ECG. If you have peaked T-waves on ECG, it means that you have hyperkalemia, meaning you are already in high potassium. So don't give potassium, because that will worsen the situation, the whole thing, to send the patient into arrhythmias. Don't give potassium if your kidney functions, if your renal functions are impaired. Because if your renal functions are impaired, remember how we are losing the potassium. It comes from the cells, it goes into the blood. Because the kidneys are functioning properly, it's filtered out. Now, if your kidneys are not functioning, if your kidneys were not functioning properly, that potassium won't be filtered out. It will remain. So if you replace the potassium, you have that potassium that was there normally, it goes into the cells, it remains normal, you add more potassium, send the patient into hyperkalemia. Only replace if the renal function is good, okay? Not when it is impaired. Or if your serum potassium is above 7. So if your serum potassium is above 7, you don't replace potassium, because this is already hyperkalemia. Now, how do you replace potassium? So remember that ECG monitoring, we do ECG monitoring, but then in our setup, it's in low setups in areas where you don't have, in some areas you may not have the ECG to monitor that. And then you have serum potassium as well. You may not have the luxury to do the serum potassium to check. So renal functions is what you can check. Mostly when you want to start, you can check your urine output. Goes back to the point that I raised earlier. You go back when you are resuscitating the patient, when you start your fluids, you give at least fluids, and when your urine output rises, you are monitoring your output. When it rises above 0.5 mils per kg per hour, then you know that your renal functions, your kidneys are working perfectly. Then you can start potassium replacement. So how do you do your potassium replacement? So you're going to be giving 20, you give 20 millimoles, okay? 20 millimoles of potassium chloride. You add it to 500 mils of NS. So you add it to 500 mils of normal saline or Ringer's lactate. So 20 millimoles of potassium chloride, you add it to 500 mils of normal saline or Ringer's lactate, and you are going to be giving you are going to be giving this every 2 hours. Every 2 hours. Sorry, not 2 hours. You are going to be giving this. You are going to be giving this after every 2 liters of fluids. This is after. So I'm going to be giving this after every 2 liters of fluids. So it's like you are alternating. So when you give 2 liters of fluids, you stop. You give the next fluid that you give. If you give 2 liters, you've given, let's say, like a 500 mils. You connect the 500 mils, it runs. You connect another one, it runs, that's 1 liter. You connect another one, it runs. You connect another one, it runs, that is 2 liters. Then the next 500 mils you connect is the 500 mils that has got 20 millimoles of potassium. You connect it there, it runs. After that, you give another 2 liter. After the 2 liter, you connect the one that has potassium. So that is how you are going to be replacing your potassium. Okay? Make sure you keep monitoring the urine output. Okay? As well. If you have ECG, make sure you are monitoring your ECG. Okay? For any ECG changes that will indicate the patient going into hyperkalemia. And on ECG hyperkalemia, you are going to see peaked T waves. You're going to have a broad QRS complex. You may have a prolonged PR interval. All those could be features of hyperkalemia. But the main feature of hyperkalemia you see is peaked T waves. So potassium, okay. So this is, you're going to give potassium chloride. Then the other principle of management is you correct the acidosis. So acidosis is rarely corrected, because as you resuscitate this patient, obviously your ketone bodies are flushed out. As you give your IV fluids, they are going to dilute the ketones, okay, and they are going to be flushed out through the urine, okay, as the patient urinates are flushed out. Okay, as you give your insulin, it's going to correct the high sugar levels and all that. And so just by you resuscitating, the acidosis is going to be correcting on its own, because the potassium starts going, the potassium goes back where it's supposed to be, the hydrogen goes back where it's supposed to be, the ketones are removed. And so usually when you have acidosis persisting, it means that you have inadequate resuscitation. So this one is rarely corrected. Unless you have severe acidosis, that's when you can think of administering things like sodium bicarbonate. Antibiotics. So this is treat and intercurrent infections with antibiotics. So these are broad spectrum antibiotics, okay? So you can start the patient on broad spectrum antibiotics. Remember, one of the main triggers of DKA is infections. So because most infections, you have a lot of infections, UTI, it could be pneumonia. So you may want to start the patient on IV antibiotics, okay? You start them on broad spectrum antibiotics. This is usually dependent on the local protocols and what's recommended. You may need to start them on antibiotics even without evidence, but maybe your protocol may say you only start antibiotics when you have evidence of infection. So it will depend on the local protocols. But you should know that infection is another thing. It's a principle that you need to cover. So make sure you screen the patient for infections, for possible infection, because that's the commonest trigger of DKA. That is the commonest thing that will send the patient into DKA. So there you have it. This is how you manage diabetes ketoacidosis. If you enjoyed the lecture, don't forget to subscribe to my YouTube channel. Don't forget to like and to share. This is What's Made Easy, Dr. Beston Mwila. May God bless you until next time. Bye-bye.